Hello, and welcome to this Ask the Expert session. My name is Vlad Ratziu. I'm a professor of hepatology in Paris, France. And today I will be providing answers to commonly asked questions about MASH diagnosis and management. The decision on which NIT should be performed after FIB-4 depends largely on the setting of work you are in and the availability of the procedures, and also about your ability to understand them and interpret the results. So there are many recommendations from scientific societies that define the second line, the third line test after a FIB-4 score. And usually those rely on the use of liver stiffness measurement by FibroScan, which is a biophysical property of the fibrotic liver, or on serum markers such as ELF, FibroTest, or ProC3. Usually the second line test would be liver stiffness measurement. And in case the liver stiffness measurement indicates high stiffness values, and therefore a high probability of having advanced fibrosis, some of the scientific societies, such as EASL, recommend even a third-line test, because still there can be a lot of false positives, either with an increased FIB-4 coexisting with an increased liver stiffness measurement. So the sequence of events here is largely dependent on what is available. But I think one of the most important messages is that once you have a high FIB-4 value, and in particular, if this is being confirmed by a high liver stiffness value, then you would have to refer the patient to a hepatologist because this needs confirmation, as we said, because of the high rate of false positives, but also because you need to make sure about the etiology of the liver disease, and sometimes etiologies can mix and coexist. There is some level of uncertainty whether there is a need even to monitor steatosis in a patient with MASLD. So in an ideal world, you would want to measure progress that is being made in a patient that had a particular therapeutic intervention by measuring the amount of liver fat content. And the only way to do that with sufficient accuracy would be through an MRI-PDFF. Now, that, of course, is not available everywhere, and it can be very expensive in some places. So therefore, this cannot apply as a general recommendation in clinical practice. Unfortunately, there are very few other methods that can be used to monitor liver fat content. One of them could be the CAP value, which is an indicator of the amount of steatosis as measured by the FibroScan machine. The problem with the CAP value is that it is not as quantitative as MRI-PDFF, not as reproducible. It might have a plateau effect with the amount of liver fat, so therefore changes in the high levels of that liver content may not be visible, and also is very operator dependent. So it is not as reliable as MRI-PDFF. Another thing that is important to mention is that measuring and monitoring steatosis over time might not be useful in patients that we simply monitor throughout the natural history of the disease without a specific therapeutic intervention. And the reason for that is that we now know from natural history studies that the amount of fat per C is not a good indicator of the disease course, of progressive disease, or of the occurrence of liver-related events. So it is not as important as monitoring fibrosis. But when you're dealing with a specific therapeutic intervention, then it might be useful to monitor the amount of steatosis, because it is something that changes early in the course of the intervention. And therefore, if you see the numbers drop, it is an important incentive for the patient to continue what he's doing, whether it's taking a drug or whether he's trying to enforce diet and lifestyle changes. The distinction between stage 3 fibrosis and cirrhosis, which is stage 4, is never an easy one. And the main reason for that is that this is a biological process that is a continuous process. It's not, there is no clear separation between these two disease states. And there's a clear progression throughout the frontier in between stage 3 and stage 4, which frontier has been set in a way that it is not on very firm grounds. It's somehow arbitrary. It's based on some histological changes. So you're never quite sure whether you're still in the F3 territory or you already stepped in the cirrhosis territory, because the distinction is quite blurred because of the biological continuum and the histological continuum between these two conditions. So having said that, that distinction is still important. There are certainly transition periods between the two, but it is important to understand whether someone already hit the cirrhosis stage, because very specific monitoring programs will need to be put in place in someone who has cirrhosis. So by and large, a very high FibroScan value above 20 in someone who's not overly obese is a very strong indicator of having cirrhosis. There are other indicators such as a low platelet count, obviously any signs of portal hypertension, which tells you that the patient has already reached a stage of well-defined cirrhosis. As far as stage 3 fibrosis, clearly someone who is below 12 kilopascals on repeated measurements is probably not yet at a cirrhotic stage. Now, there might be a gray zone in between that, and this is a difficult option, but knowing that most of the drugs that we will have now at our disposal, whether resmetirom or semaglutide, are still very safe to use in people with early cirrhosis or very advanced bridging fibrosis, very late stage 3, that is a reassuring information, because it tells you that even in cases where the distinction cannot be made with absolute certainty, at least using these drugs will not jeopardize the patient's health, and it will still have a safe profile and a good tolerability profile. So that distinction is important, I would think, mostly for initiating the monitoring of that you should do in any cirrhotic patient. It's less important when you decide that any particular non-pharmaceutical or pharmaceutical interventions are to be put in place. There is no pharmacokinetic reason why resmetirom and a GLP-1 receptor agonist such as semaglutide would not be able to be used and started at the same time. I don't see any reason why that would be the case. So the theoretical answer is yes, they can be started at the same time. Now, we don't have much experience with these drugs. We had large phase 3 data sets that have revealed the therapeutic potency of these two drugs, but that's about it. And of course, resmetirom has been used in the United States for now over 1 year. But the experience is still limited. And one of the things that we need to be aware of is that maybe we should need to test the full therapeutic potential of each one of these drugs before starting thinking about combinations. So unless there's a very good reason to start them at the same time, I would advocate a sequential approach where you would use one of these drugs based on patient characteristics, indications for therapy in each individual case, and then see how much benefit you get from that drug before adding a second drug. So the question of which drug can be used in someone who has poorly controlled metabolic dysfunction, such as diabetes, type 2 diabetes, or obesity, morbid obesity, is a very important question for the future, where hopefully now with more than one drug on the market, at least in the near future, we will be able to set in place a more individualized therapy than before. Obviously, semaglutide has a weight loss potency and also improves the glycemic profile. And those are, by the way, the two indications of semaglutide outside the liver condition. So therefore, it is clear that while resmetirom does not make you lose weight, is weight neutral, and does not improve the glycemic control, therefore, it is reasonable that if these two metabolic dysfunction conditions are at the front stage of the patient's condition, it would make sense to start the therapy by using a GLP-1 receptor agonist rather than resmetirom. Resmetirom can be used, of course, if diabetes is already well controlled, if obesity is not the main reason the patient complains about, and if the liver disease is advanced with a lot of fibrotic tissue, then obviously resmetirom can be used as well. But given the additional benefits of a GLP-1 receptor agonist on the comorbidities that are often associated with MASH, it is indeed reasonable that those comorbidities would dictate the first line, the choice of therapy. So thank you for your time today, and I hope you found this information useful.